My name is Peter Lawrence, Chief of Endovascular and Vascular Surgery at UCLA, and editor of the Journal of Vascular Publications, along with Peter Glovitsky, editor-in-chief. It's a pleasure to provide an overview of this month's Journal of Vascular Surgery. The editor's choice for this issue is readmission rates following lower extremity bypass vary significantly based on surgical indication by Melanie Morris from UAB. It used the ACS-NISQIP database from 2012 to 2014 to evaluate the reasons for readmission after lower extremity bypass, which are among the highest of surgical procedures. 6,112 patients in the database who underwent lower extremity bypass had a 15% readmission rate in the first 30 days. The readmission rate was lowest in the claudication group at 9%, while 19% of those with tissue loss as the indication for surgery required readmission, and over 50% of the readmissions were for a wound-related problem. This paper stratifies the likelihood of readmission based on indication for lower extremity bypass, as well as providing data to develop strategies to reduce the likelihood of readmission in the highest risk group of patients, those with tissue loss. The CME paper for this month is Loss of Kidney Function in Patients with Critical Limb Ischemia Treated Endovascular Surgical, written by Sichterman and co-authors from the Netherlands. It investigates the impact of endovascular and open revascularization procedures on short-term and long-term renal function. The authors found that endovascular procedures, which are often done to reduce procedural risk, actually cause more short-term and long-term renal insufficiency, and that the causes are often multifactorial. The conclusion of this study is that contrast agent and dose are important, but in spite of using renal preservation techniques to control renal damage, there was still renal impairment in both the short and long term after endovascular procedures, and that this renal impairment is progressive and often not reversible. The next paper is Outcomes for Symptomatic Abdominal Aortic Aneurysms and uses the ACS-NISQIP database and is by Soden and co-authors from Beth Israel Deaconess Hospitals in Boston. They used the prospectively maintained ACS-NISQIP database to evaluate 5,502 infrarenal aneurysms repaired from 2011 to 2013 at multiple institutions to see if there was a difference in outcome based on the three indications for aneurysm repair: asymptomatic, symptomatic, and ruptured. They found that patients with symptomatic aneurysms, which represented approximately 8% of aneurysm repairs, had double the 30-day mortality of elective AAA repair and 1/7 the risk of repair of ruptured abdominal aortic aneurysms, whether the repair was performed by an endovascular or open technique. Those who believe that symptomatic aneurysms represent an intermediate risk between elective and ruptured aneurysms have had their impression confirmed by this study, the largest so far performed in the endovascular era. The last highlighted paper is by Mary Tao and co-authors from Toronto and entitled Temporary Inferior Vena Cava Filters, Indications, Retrieval Rates, and Follow-up Management at a Multi-Center Tertiary Care Institution. They reviewed 1,123 IVC filter procedures performed from 2001 to 2013 at their combined medical centers, with 2/3 of the procedures for insertion of filters and 1/3 for retrievals. Approximately 505 were placed for absolute indications, 25% for relative indications, and 17% prophylactically, as well as 4% that were outside of established guidelines. 40% of retrievable filters were removed at a mean of 76 days. Instructions for filter management were documented in only 16% of patients, and only 43% of discharge summaries noted the filter replacement. Filters were more likely to remain unremoved when inserted on a medical service as opposed to a surgical service. This paper tells us that if we place retrievable filters, they not only should be done for appropriate indications, but there needs to be chart documentation of their presence and a plan to remove them. Although these are the highlighted papers, there are many others in this issue of the JVS that have important information for vascular specialists and that should be read. Thank you.